Yep. All right. So it's good to be with everybody today as we talk about beyond the head count, the new model of care extenders in rural health. And very interesting, innovative sort of conversation to have today. And I want you to know a little bit about me as a presenter. I'm a member of the Indiana Rural Health Association. My name's Dr. Todd Stillson, and I've been practicing rural medicine in Indiana for well over 30 years. Having grown up in Indiana, I'm a true Hoosier and performed family medicine and surgical OB in the Plymouth area. I retired in 2024 with about 5,000 patients in my practice and decided to transition from rural care in the clinic to rural care outside of the clinic and really wanted to spearhead the concept of really what I saw the family medicine of the future and what it looked like. And so I founded a company and developed some software that allows the process of asynchronous telemedicine to occur, what I consider is the most advanced model of telemedicine, and really begin building a rural health infrastructure process to support that. My goal in my heart is to reach rural patients with the medical care that they need. And over the years, I've really seen that as being a real challenge. As an example, I gave my hospital a couple years notice of the need to replace me before I was going to retire in 2024. And I naively thought that that 2-year window would be enough time for them to identify a physician to take care of the patients that I was leaving. And the reality was that took a total of 4 years to find that. And so that's just evidence, really, of what I consider the shortage of primary care physicians in rural spaces, and what I think is really a growing need that exists. And as members of the Indiana Rural Health Association, I'm singing to the choir when we talk about that, and I do understand that. So today we're going to talk about kind of a clear-eyed view of what the systems in the pipeline looks like, and really talk about the structural problem that exists, the extenders headcount model, and how that sort of has been a gap filler for us for years, but why we might need to begin to think about what I call force multiplier model and how that can really impact the delivery of care for the rural citizens of Indiana. We'll take about 30 to 40 minutes to go through the presentation today, and then allow some time for Q&A at the end, in which I'll be happy to answer any questions as any of you as participants want to ask questions. The slides will have a fair amount of content in them. That's on purpose. Medical people tend to like content, and you can review and read these later if you want. I'll try and not just be a slide reader, but also present to you really important information. And here's the beginning of the process, right? We're really in a rural health crisis. And in 2026, that's a big deal for our hospitals, with 52 rural hospitals in the state of Indiana, and 25% of them having announced plans to consolidate, join a larger system, or discontinue some level of services. We're seeing the reduction of birthing hospitals, and now it's down to 35 of our rural hospitals, and 16 OB units have closed in the last 5 years, one of which included the hospital that I was working at here in Plymouth. We're seeing projected Medicaid cuts in terms of the funding, and we're just seeing hospitals being at risk of closing, with as estimated as much as 16% of our rural Indiana hospitals at risk for closing. We're seeing critical access hospitals operating at a loss, and the bottom line is it is a growing crisis, and it's not just coming, it's really here. And we have to kind of react to this and figure out how we're going to manage the ongoing demands for acute care access and access to care in general. The reality is that the ER has become the rural safety net. Now, if you watch shows like The Pit, you know in urban areas, it's also becoming a big safety net. But in our rural population, it's also affecting us there, and we're really reaching that breaking point where we know from the data that about 24% or so of patients that come to the adult ER really could have been managed somewhere else. They did not need to come to the ER. And that kind of translates to as much as 29 to 30% of ED visits are kind of avoidable nationally, and they could be treated elsewhere. We know that in the rural areas, this kind of movement is even more pronounced, where as many as 49% of ER visits could have been avoided as non-urgent. And we're just seeing this growing use of the ER in rural populations. And our Indiana Department of Health, has recognized this, that there's been an uptick of almost 12.5% of ED volume, especially in northern Indiana, where I'm coming from, that we see this kind of growing sort of safety net that the ERs kind of meeting those needs. And here's the reality, though, that's our highest level of cost per care, right? And when somebody goes to the ER, the average cost is $1,000 to $3,000, right? And it's because they are covering a whole bunch of risk management features associated with the ER, and it's just kind of baked in. And that's compared to an urgent care where the could be 150 to 300 bucks, or a primary care office, 75 to 150. And then we have this emerging asynchronous virtual care options that are growing, and those are much less expensive. And I think if we are honest with ourselves, we need to think about how we can unload or offload some of these ER visits into these other care models. Um, and the reality, though, is that our response to that is typically we just need more people. We need a head count to fill the gaps. And the reality on that is, too, as I mentioned, that the provider shortage is not new. It's actually deepening, though, and many of our rural communities are facing provider, doctor, and PPA gaps that have been building for decades, and really creating a lot of pressure on the health systems and the healthcare providers to sort of meet that need. The rural health workforce in numbers is it's a real challenging situation right now, 50% of the US population are in communities of 25,000 or less, and 20% of them are in populations of 5,000 or less, and a lot of those are obviously in Indiana as well. Yet only about 10% of physicians and about 14% of NPs practice in rural areas. So we already start to see this gap of where people are located and where providers are that are existing in just a growing gap of shortage, right? And we know that 60% of healthcare shortage areas are rural. We know that 30% of the current workforce, physicians are anticipating retirement over the next 5 to 10 years. And frankly, a disproportionate number of these work in rural areas. And we also know there's a timeline, right? A pipeline associated to get a physician from the medical school into independent practicing rural environments. And that process can take 7 to 10 years at a minimum. And that just creates a tension that demands some sort of accelerated pipeline or some way to sort of manage this. And the reality is, right here in Indiana, when we drill this down beyond national stats, the fact that there's 71 counties in Indiana that have a healthcare shortage, and 30% of the population is rural in Indiana. There's 1 to 2 million patients that are underserved in Indiana. This is sort of a big issue, right? And it comes back to the idea that we're having difficulty as a root cause of keeping up with the recruitment process to bring physicians into our rural communities to solve this problem, right? And there's a pipeline attrition. Medical trainees who begin their career, even with rural intentions, frequently end up shifting towards subspecialty and urban practices before completing their training. And I've been involved in medical education of doctors for many years, from students all the way to residents. And I've seen this shift happen over the past 10 to 15 years. And here's the reality: 14% of physicians at age 60 plus practice in rural areas. So a lot of the rural areas are populated with older doctors, yet only 4.3% of physicians under 40 practice in rural areas. So what that means is, right, the younger doctors are not going to rural areas to locate themselves. There's a lot of data that shows when it comes to the recruitment side of the equation, how many physicians, young physicians, when are being recruited, express an interest to go into a rural area. The answer is 0%. And it only bumps up to about 1 to 5% if you're talking about communities of 25%, 25,000 or more. It's getting more and more difficult to attract physicians to rural areas. And all of you on this call who have been in that position of trying to make that happen, you know what I'm talking about. And here's the reality is that you're going to have a better chance, right, when for you to find a physician that wants to come to your area if there's nearby family or friends, right? Or there's proximity to urban options and urban lifestyle, or there's some sort of outdoor geographical alignment with some interest that that physician may have, or perhaps that physician has rural roots of some type. But honestly, a lot of younger physicians are looking at the what happens in a rural practice, and they don't like the idea of the call burden associated with smaller practices, or the professional isolation that happens, or the limited spousal employment opportunities. And quite honestly, many of the younger population of physicians are just choosing not to come to rural areas. And then there's just the financial misalignment, right? That they're just the payer mixes are different. The pay itself is going down in terms of reimbursement, and even the loan repayment programs that do sometimes attract physicians to state level incentives and even national incentives barely close the gap, and sometimes don't close it enough to make a difference. And so we just see this whole trend line happening. And so, in the past, our approach to these issues has been the answer is found in a head count. We recruit more providers. We recruit them in more sophisticated ways. We give them more incentives. We kind of jump into this 7 to 10 year pipeline and begin signing people even younger in the pipeline. And we grow the individual physician's capacity to care for more patients, and we try and reduce the risk for burnout, but the risk is there. And what we really haven't leaned into heavily are what I call force multiplier strategies. And that's where we really grow what the provider themselves can do and how much work they can manage. Now, we have leaned into this through some physician extender models like NPs and PAs that we're going to talk about. But there's also virtual care and AI assisted and asynchronous care models that are coming, and we're going to talk a little bit more about this. But what we want to really and need to focus on is developing scalable capacity that allows us to fill the needs that rural communities have. And this is really, really important because right now it feels like we're in the zero sum game of, we're replacing some, but you're really not gaining in the zero sum game. And then in terms of even how many patients those physicians can manage, it just feels like we're really not getting ahead. And then you throw in physician burnout, economic strain, pipeline lag, and really it feels like it's a game that we just can't get ahead of. And so today's force multipliers that we use for expanding physician capacity, in other words, so we can allow physicians to see more people or manage more, are the NPs and PAs, kind of our original workforce multipliers. We have team-based care models. We have workflow optimization and support staff models. And frankly, in a rural practice like I've been in, I've used all of these. And we're going to take a minute just to explain and walk through those. Those are still important ways for us to multiply what an individual physician can do in their capacity to care for patients in rural communities, but there are limits to that. And so, this next slide sort of walks us through what the impact is, right? And advanced practice providers really can, under supervisory models, expand significantly the number of patients or the number of the population that an individual physician can take care of. Team-based care, workflow optimization, all of these add percentage points to the equation, and that all rolls down even into some of the new AI documentation processes that we're seeing many physicians adopt. We have telehealth 2.0. And then even what I'm going to talk a little bit more about is telehealth 3.0, which is more of an asynchronous model. All of these end up being force multipliers that can make a difference for physicians, medical practices, and the hospitals that employ them, right? We know that MPs and PAs for years have been filling these gaps, and they're so important to the ecosystem at each one of our rural hospitals and facilities. And what we've seen when I think about this, I've been the county medical society president for over 30 years in our county here up in northern Indiana. And the reality is what we've seen is though that's been populated heavily by physicians when I started my career. And now at this point in my career, the numbers of NPs and PAs far outweigh the number of physicians that are in any county sort of medical association, so to speak. And we know this that right that as much as 36 to 50% of visits are seen exclusively by PAs and NPs in rural sites. And for some of you, that may even be higher. The reality is that NPs and PAs are really a critical part to helping us to reach more people and take care of people. And it's going to be a continued growing model, right? Because they can fill a lot of these gaps in primary care, even in chronic disease management care, working with specialists or providing specialty-based clinics. And they provide a lot of the urgent care and acute care throughout many of your health systems. And there's a growing force of them that are also involved in behavioral health and providing psychiatric care because of the psychiatrist shortage that exists. So the NPs and PAs of the world have been proven to be very effective. But again, even on that level, we're kind of reaching that point where there's a ceiling, just like for doctors, there's a ceiling. And it takes some time to get those nurses, those NPs and PAs into that pipeline. There's still sort of this appointment-based scheduling, kind of capacity that NPs and PAs can take care of. And it's sort of a finite multiplier, really, what NPs and PAs can provide. Again, it provides a ceiling. And then let's not forget the nursing shortage that kind of lurks behind the background in terms of a support staff for any medical clinic or even the pipeline for an NP that starts out as a nurse and then becomes an NP. There's just this same issue in the NP and PA world. And quite honestly, a lot of the NPs and PAs are favoring urban or suburban settings over rural settings nowadays as well. And again, over my 30 years of practice, I've seen that migration happen. And so it's just a very interesting phenomena. I think NPs and PAs are clearly going to continue to play an important role for us, but they have their limitations as well. Team-based care, kind of a physician extender model under one roof. I've been the part of a patient-centered medical home where we had multiple caregiver models from pharmacists to behavioralists to RNs providing a certain level of care for chronic disease management in underneath one roof that was sort of co-managed by me or as a physician. We see the same model that exists under the FQHCs of the world that have dental providers even or social workers and others under one roof. And these are again great models where you can take the physician and their skill and sort of extend it out across a number of the caregivers that have can provide reimbursable services in the system. And then we have various levels of integrated behavioral health and pharmacy models that exist from your local pharmacies to the behavioral health businesses that are now kind of foraying themselves into even medical provision. So there's just this overlap providing having a physician and using a group of people around a model to help provide care to more people in a more comprehensive package. And again, will always need to be an important part of that solution. We have structured support, amplifying physician capacity, right? A team care model where you might have NPs, PAs, nurses, even medical assistants that are collaborating with the doctor and really prepping a visit, preparing for the visit, and then helping to offload the scribing part of a visit to even the ordables that come out of a visit. There's these standing order sets that can exist in a practice that allow a physician to manage more messages and manage asynchronously a lot more care and sort of empower a clinic staff to do more of the work on their behalf. But even though they are the responsible party. And so, again, sort of getting just a little bit more workload out of a doctor is really sort of an art, okay? But what we're seeing are in all these tiers, they're all under pressure. The physicians are being asked to do more. There's less of them going to rural areas. They're becoming much more inefficient in terms of how they can manage things. The NPs, the PAs, and even the registered nurses are all in the crosshairs of this headcount answer and the challenges that we have, and then throw in this, statistic we're all very familiar with, right? Because of those growing burdens and growing workloads, we see this workforce crisis of burnout. Again, all the way across the board, from doctors to NPs to PAs to nurses. And what that leads to, right, is those providers leaving the system, leaving your network, leaving that community because they can't manage the burden associated with it. On the backside, the EHRs, I think, have been a key part of that. But we have new emerging models that I think are providing some true relief for medical providers in that context through AI assisted and ambient AI models. But again, it's coming, it's not quite here. And so we kind of had this mindset that I believe has been pervasive for us in rural settings, and that is that headcount is the answer, right? That we recruit and replace the doctors, medical staff, PAs, NPs that are leaving one by one. And then we try and retain and support those who are there. And if we're growing our market share, that we kind of extend capacity and all the different models that I've shown. But the reality is that it's sort of a bit of a losing battle, okay? And it's really going to require some innovation to extend and multiply and really leverage AI and technology to provide, I think, the next level of care. And this is what's really emerging and growing. And quite honestly, it's what I've stepped into and become and passionate about in terms of how we can scale physician capacity through technology assistance and not just growing the number of physicians. Virtual care expansion, we've seen it, especially since COVID has become a huge model of care. We're now seeing AI and automation coming on the scene. As many as 80% of physicians are using AI in some capacity every day, from documentation to administrative tasks to preliminary diagnoses. There's just all sorts of ways freeing up physician time and capacity. And then it really is also providing, through technology, data-driven insights that allow us to optimize and resource physicians, medical clinics, and medical providers in a different way. But one of the things I want to point out to you, there's kind of been three generations of telehealth that exist. Generation one was what I would call telemedicine 1.0, which was the old telephone call to the clinic office where a nurse triage line helped the patient optimize where the right level of care was for them, whether it needed to be the ER and maybe an urgent care or an appointment in the clinic, and the when of that appointment. Is that today? Is that tomorrow? Is that in a week or two? And those triage nurses in that telemedicine 1.0 model were really key, and they continue to be important. And most of your clinics have that model built into them. Then we had generation two, which was what I call location independent access in a virtual workforce. So now we begin to bring in audio visual visits that could be provided by the doctor or provider in their clinic or to a third party or independent workforce that you could contract out to provide services through a high speed broadband Wi-Fi network. And there were limitations because of that, and especially in rural areas. And I know that our Rural Health Association has been instrumental over the last decade plus to working hard to get that Wi-Fi, broadband Wi-Fi available to as many in our rural counties as possible. But there still are limitations to that. And that model still is appointment-based, still daytime-based. There's not weekend and nighttime coverage. And clinicians still, frankly, have to spend quite a bit of time gathering history information. It does extend the capacity a bit, but there's still limitations to it. And now what we're seeing is this really third space, this generation three telehealth, which is more of a multiplier, which involves the use of asynchronous care. Our telemedicine 3.0 uses a structured use of AI, AI assist through the clinical automation, chat-based workflow rather than audio visual, and it can use a cellular network rather than a high-speed broadband Wi-Fi network. Patient's information is organized and brought to the physician who uses their time wisely for clinical decision making. And then the workflow for the patient proceeds after that through, again, the use of technology. And this kind of non-appointment 24/7 on-demand care mirrors to a large extent what consumers already experience in other industries and the expectations they have for that, from travel to banking to shopping to transportation to groceries and meals, is what patients have come to expect. And frankly, we've been a little slower to the dance at healthcare when it comes to that. And so I want to introduce to you today what I think is an important force multiplier for us to think about, and that is an AI assisted asynchronous care model. And asynchronous means, right, not in real time. And so in this particular case, the physician or the medical provider, the NP or the PA, are not interacting with the patient necessarily in a live audio visual process, but they're using the best of chat and technology to asynchronously get to the medical provider the right information they need to make the right decisions at the time. And we're leveraging technology and artificial assistance to assist in that process and allow for non-real-time patient interaction. That allows us to do automated triage and screening, and that's a really big game changer because patients then can have their information and questions they have sorted out on their time and their availability. It allows for efficient patient communication, really, when optimized in the right way. And it also allows for streamlined documentation and pre-charting so that, again, the medical provider's care is sort of narrowed down to what is the most important decision that needs to be made for this patient at this moment in time that requires the physician's license and skill to make that decision and provide that level of care. And we're seeing this sort of process play out in many states and many places throughout the nation, and including right here in the state of Indiana. So you may ask, how does an AI-assisted asynchronous care work? The patient really initiates input and AI triage. They get on and just think of it like a text chat in a properly secured environment, and the AI guides them through a dialogue or questionnaire or symptom environment, and they answer those questions in your convenience. And again, for a lot of you, if you think about how you do some of your other services nowadays through banking and others, that again, you're used to this chat-based interface that is used to a large extent. The AI then structures that medical information, provides it in a summary fashion, in a clinical way that makes some sense to doctors. It presents it to the doctors in what we would call a store and forward modality. And the doctor asynchronously reviews the critical information that's been packaged for them. And they make the decisions about treatment, care, or management. And then the AI, our technological assistant, or even perhaps a nursing assistant, communicates the follow-up and information for this. This all streamlines a lot of the inefficiencies of how the system currently works and allows the medical provider's care to be scaled up in terms of the number of patients they can see and manage over a period of time. And that's kind of how that works. And, are all conditions appropriate for asynchronous virtual medical care? Absolutely not. There are a lot of things, though, that are an acute, low acuity care, such as common infections, UTI, sinusitis, pink eye, etc. Yeah, they definitely are. Dermatological concerns, definitely are. Seasonal allergies, even stable medication refills. These are all areas that an asynchronous virtual medical encounter can provide care for. And again, these are ongoing throughout our country right now. And so chronic disease follow-up, even using remote patient monitoring integration, again, has its place for asynchronous virtual Medicare, whether it be from hypertension to diabetes to lipid, thyroid, even stable depression, anxiety, ADHD, asthma control, obesity. I mean, look, we've all seen the GLP-1s just flooding the airways and the number of patients using them. And marketing companies have wisely recognized the potential here And I don't want to go down that rabbit hole too far in terms of some of them have been very unscrupulous in their processes. But the reality is that kind of gives us some idea of what the patient demand is and how we can orchestrate that wisely in an asynchronous manner. There are definitely moments where you do need escalation to an ER in a very acute process, such as chest pain, shortness of breath, complex pediatric fevers, mental health changes, new complex diagnosis, any red flag symptoms. You really have to orchestrate in terms of your technology the right determination to know when does a patient need to be seen face to face in person by a real human versus what is a good candidate for acute, asynchronous, low acuity care. But it is possible to sort those out. And really the question is, what does force multiplication actually mean in practice? And it's really a military doctrine that was developed as a way to expand capability without growing, adding personnel to the existing force. And so when you think about what can we do to improve or increase how an individual physician or PA or NP can provide care to more people? That's what we're talking about with force multiplication. Again, that's on one end of the spectrum compared to just growing the head count. And here's what the data shows when it comes to force multiplication. About 60% of primary care visits could be candidates for asynchronous pathways without compromising clinical quality. That's based on real research data. And so you can reduce the administrative burden for physicians and medical providers in their clinic by as much as 40%. You can increase access to care budget by as much as threefold by integrating asynchronous models. And you can actually even get greater productivity and revenue in place because of the way that you've shifted low acuity care and high acuity care. And as we all know, higher acuity care is reimbursed highly. So you're getting actually more revenue and reimbursement generated by hour of work by provider by making some of these shift. You provide 24/7 patient access, and the system saves, as you saw on the previous slide, rather than just sending patients to the ER, which costs thousands of dollars. We can shift this into lower cost, lower acuity care, and everybody's kind of a winner. The patient is, the doctors are, and the payers are as well. And then there's this kind of gap that we know that exists that people don't like to talk about, but there's this after hours and weekend challenges. And in rural environments, this is just a growing problem, right? And there's a lot of rural counties that don't even have urgent cares or after hours. And again, everybody's sort of funneled into the ER as the only solution. And here we know about providers, right? They dread taking that call on the weekend and that constant disruptions to their personal life that increases their risk for burnout and really managing non-emergent issues when they're on call. And this creates a real problem, right? Because when those physicians then don't want to come to those areas because of that burden, you can't even recruit them or get them to come, or perhaps they do come and they get burnt out, and it really exacerbates that ongoing access issue. And innovative AI-powered solutions like Telehealth 3.0 provide patients with a physician-governed access that provide clinicians with really sort of a greater quality of life. So you can augment what the physician's doing in their clinic with this after hours and weekend coverage. Suddenly technology becomes a way for the capacity of that doctor to care for more people in that 24/7 hour window to grow significantly. Because here's the reality. We know that really AI has become the unofficial first responder for patients. We know 50 to 60% of patients are turning to Gemini, ChatGPT, and Claude to ask their medical questions. I mean, it's happening every day in the US, and it's even exacerbated a little bit more in the rural areas where the access is an issue. And that's because patients have limited access to care. They have after hours needs. They're seeking information and they're turning to these large purveyors that are accessible to them on their phones via cellular network, and information about their health. And they're chatting with these AI bots from these non-healthcare companies who are sort of providing pseudo healthcare answers. And the reality is that all of these companies, from OpenAI to Microsoft to Claude, they've all developed healthcare lines because they recognize that there is such a huge need and a demand from patients that they are trying to fill that gap by improving the quality of the advice and the care that's delivered in those generic sites. And this really brings me to the fact that this is an unseen threat to our medical providers and our hospitals. And if you do not have a virtual care strategy that's 24/7 in your system, you run the risk of missing a huge and missing this gap that exists for patients in your area. And if you don't have a strategy for addressing that, you run the risk of them being successfully wooed by the big tech companies, who, by the way, their intentions are not quite as altruistic, right? They're interested in an ecosystem that aligns them with big purveyors of medical care, like Amazon One Health as an example, and other large corporations that are providing healthcare. And so the way that looks in their B2B relationships is, right, they had to cast this big net. ChatGPT Health sort of it talks to the patient, so to speak, because they're instantly available, and the patient then is not directed to your clinic or your facility, your hospital. They're actually handed off to Amazon One Health, on a virtual visit to take care of this for them. So the reality is this, that passivity about your virtual health and first responder strategy could lead to some system leakage and loss of downstream dollars. And so it's important for us to recognize what's happening on a larger scale and to begin to respond to what patients' needs are, and what could be possible for you. Because the reality is that patients face unique barriers in rural settings, and they have big distance and transportation issues. They have work and time constraints. They have appointment scarcity. They really have multiple social determinants of health barriers that often keep them from getting the care they need. Now, the reality is that this is moving forward at such a rapid pace when it comes to technology that the policies and payment processes are trying to catch up with it. Okay. And so at this point, Medicare and Indiana Medicaid do not reimburse asynchronous chat-based provider visits. Okay, and so it's important for you to recognize that, if you're reflecting on this a bit, and that's because they require there's to be an established provider-patient relationship at the beginning, and they also require the use of audio or visuals for telehealth visits. And so that asynchronous chat-based technology does not fit into that. Now, you should know that on July 2nd, the Centers for Medicare and Medicaid Services proposed creating new Medicare payment categories for algorithmic driven care called software as a medical service that includes up to 36 codes. So the federal government and Medicaid are beginning to get their mind wrapped around this asynchronous medical provision of care and are beginning to create the codes that would support that. And that's an ongoing process. So it's coming. It just has not arrived here. Commercial insurances, they cover it. All major commercial payers cover asynchronous telehealth. You use a modifier, GQ, and that specifically denotes an asynchronous telemedicine was used. And there's a billing process associated with that. In addition to that, most of the insurances have HSA, FSA plans that often will cover any out-of-pocket asynchronous medical care provided to patients. As a whole, asynchronous telehealth tends to be a very low-cost item compared to the other care delivery models in the healthcare ecosystem. And so it's much more accessible and, frankly, is very amenable to direct-to-consumer cash-based services. And we know this is a growing model of care, whether it be direct primary care or other cash-based services that patients are now accessing. And in Indiana, law allows for store and forward telehealth technology, and many patients are just simply using cash to pay for that care because it's available, it's convenient, it's accessible, and it's the care that they need in the moment. So what does all this mean to our IRHA members? We need to do some due diligence, but there's some work being done with Indiana Grow Grant that's part of the Rural Health Transformation Federal Act that's going on, and we're seeing some innovation beginning to take place when it comes to providing asynchronous medical care to our communities. And I know I'm playing a part in the Region 1 of Indiana in growing an integrated rural access network in our area. And there's also proposals being accepted by the state right now to build a telehealth access and infrastructure through innovation throughout the state. So we see our state sort of adopting these concepts and supporting them, and we know it's coming. And I think if you're a critical access hospital, you're a RHC or an FQHC, or an independent practice even, you need to begin to think about what this could look like. And the answer is not a one size fits all answer. The answer is highly variable in terms of what that looks like in terms of value-based care, what that looks like in terms of the models of your ecosystem. But it's important for you to begin to recognize this. And what we're seeing on my end of the equation through the work I do with an asynchronous telehealth product like ChatRx is that we see independent pharmacies and groceries and in schools and universities adopting this because it's answering the question that they've had for many years, and that is, how can we get access to care for the people in our communities, in our areas that we're delivering services to, the right level of care when they need it. And the access has been so broken that they're looking for solutions and they're gravitating towards these virtual care options. We're also seeing a large uptick in employee health and business partnerships that when all of these things combine, they could create the potential for an infrastructure to be developed, okay, a network, so to speak, of developing a front door process where a lot of us can work together to collaborate in a virtual sense to reach as many of the patients as possible, and to provide care to as many as possible through all sorts of ways that we can network together. As an individual healthcare organization, there's a lot of different ways to do this. You can do it from an in-house co-branded white label version, working with a tech partner, or you can partner with a vendor managed or third party and allow that to be totally outsourced to them. And there's all sorts of options in between to really help create that network effect. But the reality is that telehealth 2.0 is here. It's very important, but this telehealth 3.0 is on its way as well. If you're a leader and you're thinking about how you can adopt these sort of force multiplier options, just some points for you to think about: clinical governance. How is that technology governed? We're very strong as being a physician-led company and physician with a doctor in the box sort of mentality about how our software has been developed, but not everyone is. Some marketing companies that are really led by marketers and people are out to make a buck, and they don't have a strong clinical governance. Workflow integration in your system, how it fits into your ecosystem, what is your patient population, and then again, what is the financial sustainability of how this might fit into your system, are all important questions for you to carry and think about. What to carry forward from today's session is the head count has a ceiling. Don't give up on it. Go out, recruit, seek to retain who you have. Replace them one by one. Grow them if you have that power to do that. But again, just know that there's a ceiling in terms of the volume of care that and the capacity that those providers have. And this doesn't just include doctors, it includes your NPs and PAs and others who also are an important part of that extension model. And you've got to recognize the answer just isn't headcount in that area. So telehealth 2.0, telehealth 3.0, our asynchronous AI-assisted care is becoming this new force multiplier that could be one of the solutions for you to consider. And then just think about how you might implement this with deliberate governance and questions. Okay, I mean, in terms of your implementation plan. So I'll now entertain any questions that any of you may have about this, and happy to do that.
Well, thank you. That was very informative.
Okay, I'm glad to share that. And I know a lot of, again, isn't this kind of funny, right? We are going to have a lot of people listen to and watch this asynchronously, right? So there's a few
Mhm.
people ever attending this, but that just gives evidence to the fact that we all use asynchronous technology almost every day in how we professionally do the work that we do. And now what we're talking about is bringing that into the healthcare model. And I think it's fascinating. I think it's interesting. And in my opinion, it needs physician leadership, which is why I've dedicated my next stage of my career to that process.
All right. Well, I don't see any questions in the chat and
Okay.
nobody's raised their hand. So I just want to thank you for your presentation today.
Yes, thank you,
And again,
Carolyn.
it will be recorded, or it was recorded, and it will be on our YouTube channel. And like I said, in about a week.
Very good, Carolyn. Thank you for allowing me to give this presentation, and I look forward to any asynchronous communication that members of our Rural Health Association have as they watch this presentation later. You can reach me by phone or by email, as I mentioned in the second slide, and I'm happy to answer any questions if people have them.
Yes, thank you. And if anybody has any questions, we will definitely forward them to you for you to help them with them questions.
Okay.
All right. Thank you. Everybody have a good day.